Incontinence, fecal Kalyan Akrishnan Ramakrishnan, MD. Basics: continuous or recurrent involuntary passage of fecal material through the anal canal for greater than 1 month in an individual at least 4 years of age involves recurrent, involuntary loss of solid/liquid stool, requires careful rectal exam to assess rectal tone, voluntary squeeze, and rule out overflow. Incontinence from fecal impaction. Endorectal ultrasound, EUS, is the simplest, most reliable, and least invasive method to detect anatomic anal sphincter defects. The goal of treatment is to restore continence and/or improve quality of life. Description: major incontinence is the involuntary evacuation of feces. Minor incontinence, fecal soilage, includes incontinence to flatus and occasional seepage of liquid stool. Geriatric considerations: the prevalence of fecal incontinence increases with age. It is an important cause for nursing home placement among the elderly. Idiopathic fecal incontinence is more common in older women. Epidemiology: incidence: patients often do not report fecal incontinence unless specifically queried. Silent affliction. The number of affected patients is likely significantly underestimated. Prevalence: women, men 7% of adults, 15% of adults age greater than 90 years, 66% of hospitalized older patients, and 50% of nursing home residents. 50–70% of patients who have urinary incontinence also suffer from fecal incontinence. Pregnancy considerations: obstetric injury to the pelvic floor may result in either temporary or persistent incontinence. Geriatric considerations: fecal impaction and overflow. Diarrhea leading to fecal incontinence is common in older patients. Surgical history, particularly anal surgery, including hemorrhoidectomy, anal fissure repair, sphincterotomy, anal dilatation, or prior pelvic floor surgeries. Etiology and pathophysiology: continence requires the complex orchestration of pelvic musculature, nerves, and reflex arcs. Stool volume and consistency, colonic transit time, anorectal sensation, rectal compliance, anorectal reflexes, external and internal sphincter muscle tone, puborectalis muscle function, and mental capacity each plays a role in maintaining fecal continence. Disease processes or structural defects impacting any of these factors may contribute to incontinence. Diabetes is the most common metabolic disorder leading to fecal incontinence through pudendal nerve neuropathy. Congenital, spina bifida and myelomeningocele with spinal cord damage. Trauma, anal sphincter damage from vaginal delivery or surgical procedures. Medical, diabetes mellitus, stroke, spinal cord trauma, degenerative disorders of the nervous system, inflammatory bowel disorders, rectal neoplasia. Risk factors: poor functional status, older age, female sex, obesity, limited physical activity. Contributory neuropsychiatric conditions, dementia, depression, multiple sclerosis, spinal cord injury, stroke, diabetic neuropathy. Prostatectomy, radiation trauma. Risk factors for perineal trauma at the time of vaginal delivery include occipito-posterior presentation, prolonged second stage of labor, assisted vaginal delivery, forceps or vacuum assist, and episiotomy. Diarrhea, inflammatory bowel disease, IBD, irritable bowel syndrome, IBS, menopause, smoking, constipation. Potential association with child abuse and sexual abuse. Congenital abnormalities, such as imperforate anus/rectal prolapse. Fecal impaction. General prevention. Behavioral and lifestyle changes, obesity, limited physical activity/exercise, poor diet, and smoking are modifiable risk factors. Post-meal bowel regimen: defecate regularly after meals to maximize effect of gastrocolic reflex. Pelvic floor muscle training during and after pregnancy and pelvic surgery. Increase fiber intake, greater than 30 g/day. Commonly associated conditions: increasing age, greater than 65 years, urinary incontinence/pelvic organ prolapse. Chronic medical conditions: diabetes mellitus, dementia, stroke, spinal cord compression, depression, immobility, chronic obstructive pulmonary disease, IBS, and IBD. Perineal trauma, obstetric, Anorectal surgery. History of pelvic/rectal irradiation. Diagnosis. Diagnosis is based on history and physical findings. History. Patients seldom volunteer information about fecal incontinence. Direct questioning is important. Problem-specific history includes 1. C. Severity of soiling by liquid stool or gross incontinence of solid stool. Onset and duration, recent onset versus chronic, frequency, presence of constipation/diarrhea. Medication review. Review diet, medical and obstetric history, lifestyle, and mobility. Evaluate for social withdrawal and depression. Physical exam. Inspect the perineum for chemical dermatitis, hemorrhoids, fistula, surgical scars, skin tags, rectal prolapse, soiling, and ballooning of the perineum, sarcopenia of pelvic musculature. A patulous anal orifice may indicate myopathy or a neurologic disorder. Evaluate the external sphincter response to perineal skin stimulation, anal wink. Absence suggests neuropathy. Ask the patient to bear down, preferably in standing position, to assess for rectal prolapse. Digital rectal exam to assess anal canal pressure, sphincter tone, rectal bleeding, hemorrhoids, neoplasm, fecal consistency, and diarrhea/distal fecal impaction. General neurologic examination, including perianal sensation. 1. C. Evaluate mental status. Differential diagnosis. Anorectal disorders, inflammatory/infectious gastrointestinal disorders, bowel neoplasms, radiation proctitis, ischemic colitis, fistulas, prolapsed internal hemorrhoids, rectal prolapse. Trauma, obstetric, surgical, radiation, accidental, sexual neurologic disorders, stroke, dementia, neoplasms, spinal cord injury, and/or diseases causing altered level of consciousness. Pudendal neuropathy, neurosyphilis, multiple sclerosis, diabetes mellitus. Miscellaneous causes: infectious diarrhea, fecal impaction and overflow, IBS, laxative abuse, IBD, short bowel syndrome, myopathies, senescence and frailty, collagen vascular disease, psychological and behavioral problems. Diagnostic tests and interpretation. The approach to fecal incontinence in older patients should be individualized, minimally invasive, and practically feasible. History and physical examination are generally sufficient for diagnosis. If uncertainty remains, consider the following. EUS is the most reliable and least invasive test for defining anatomic defects in the external and internal anal sphincters, rectal wall, and the puborectalis muscle. 1. B. EUS can reliably predict therapeutic response to sphincteroplasty. Plain abdominal X-ray, fecal impaction, constipation, sigmoidoscopy/anoscopy/colonoscopy, hemorrhoids, colitis, neoplasm. Initial tests, lab, imaging, if history of travel, antibiotics, tube feedings, or signs and symptoms of sepsis, consider stool. Studies, culture ova and parasites. Clostridium difficile toxin assay. Thyroid stimulating hormone, TSH, electrolytes, and blood urea nitrogen in elderly patients. EUS may demonstrate structural abnormalities of the anal sphincters, rectal wall, or puborectalis muscle. EUS may detect a sphincter injury in over 1/3 of primiparous vaginal deliveries and nearly half of multiparous vaginal deliveries. Follow-up tests and special considerations. Defecography can measure the anorectal angle, evaluate pelvic descent, and detect occult/overt rectal prolapse. MRI defecography, dynamic MRI, can further define pelvic floor anatomy. Anorectal manometry measures parameters such as maximal resting anal pressure, amplitude, and duration of squeeze pressure, the rectoanal inhibitory reflex, threshold of conscious rectal sensation, rectal compliance, and anorectal pressures during straining. Pudendal nerve terminal motor latency, PNTML, measures neuromuscular integrity between the pudendal nerve and the anal sphincter, is operator dependent, and has poor correlation with clinical and histologic findings. Electromyography can assess neurogenic/myopathic damage. Treatment: general measures in ambulatory patients, scheduled, or prompted, defecation is effective, particularly in those with overflow incontinence. Kegel exercises to strengthen pelvic floor if bedbound, scheduled osmotic or stimulant laxatives for constipation enemas, laxatives, and suppositories may help promote more complete bowel emptying in impacted patients and minimize post-defecation leakage. Use of stool deodorants, peri-wash, Durafil, Devrom, medication. Limited evidence that antidiarrheals, loperamide, codeine, and drugs enhancing sphincter tone, phenylephrine gel, sodium valproate, are of benefit. 2b. Cholestyramine, cholestyramine useful in diarrhea following malabsorption or cholecystectomy, allosterone in diarrhea due to IBS, amitriptyline in idiopathic fecal incontinence. First-line specific treatment of underlying disorder, e.g., infectious diarrhea/IBD, may improve fecal continence. Second line, increasing dietary fiber in milder forms of fecal incontinence reduces symptoms. 1b. Stool bulking agents include high-fiber diet, psyllium products, or methylcellulose. Antidiarrheal agents, such as adsorbents or opium derivatives, may reduce diarrhea-associated incontinence. 1c. Disimpacting patients with fecal impaction and overflow incontinence and treating with a bowel regimen to prevent recurrence. Additional therapies. Biofeedback, initial treatment modality in motivated patients with some voluntary sphincter control. 1c. Teaches patients to recognize rectal distension and contract the external anal sphincter while keeping intra-abdominal pressure low. Biofeedback plus electrical stimulation of the anal sphincters is more effective than either alone. Patients with systemic neurologic disorders, anal deformities, or frequent episodes of incontinence respond poorly. Surgery/other procedures. Surgery should be considered only when non-surgical approaches have failed. Sphincter repair should be offered for highly symptomatic patients with well-defined defect of external anal sphincter. 1a. Injectable therapy. Tissue bulking agent injected into the anorectal submucosa or the intersphincteric space, appears safe and effective, 40% efficacy, for patients with internal anal sphincter dysfunction. 3a. Artificial anal sphincter implantation/dynamic graciloplasty, where gracilis muscle transposed into anus as modified sphincter, considered in patients with severe fecal incontinence and irreparable sphincter damage. 4b. Stoma, colostomy/ileostomy. Creation may be appropriate in patients with disabling fecal incontinence when other available therapeutic options have failed or if preferred by patient. 1b. A continent stoma created using the appendix or the cecum as the point of entry is a less radical option and enables using antegrade continence enema to flush the colon in these patients. Anal plugs minimize fecal leakage in patients who do not benefit from other treatment modalities, especially immobilized, institutionalized, or neurologically disabled patients. Plugs often poorly tolerated. 1c. Sacral nerve stimulation, neuromodulation, via implantation of SC electrodes delivering low-amplitude electrical stimulation to sphincter muscles improves overall rectal tone, especially in patients with a coexistent sphincter defect. 5b. SECA procedure, radiofrequency anal sphincter remodeling, temperature-controlled radiofrequency energy delivered to the anorectal junction distal to the dentate line causing tissue damage, scarring, and anal canal narrowing. Minimally invasive, ambulatory procedure useful in mild to moderate fecal incontinence. 1c. Magnetic anal sphincter, MAS, devices series of interlinked titanium beads, 14 to 20, with internal magnetic cores placed to form a flexible ring that encircles the external anal sphincter 3 to 5 cm from the anal verge. During expulsion of feces, the beads separate allowing evacuation. After evacuation, the beads approximate closing the canal. 5c. Useful in moderate and severe incontinence. A vaginally placed bowel control device that the patient inflates to control leakage and deflates to defecate is well tolerated and effective in 86%. 5b. Percutaneous posterior tibial nerve stimulation at the ankle for 30 minutes weekly for 12 weeks, 50% efficacy, and the Topus pelvic floor repair system, self-fixating polypropylene. Mesh placed behind the anorectum to support the puborectalis, 55% efficacy, are other recent advances in controlling fecal incontinence. 5b. Admission, inpatient, and nursing considerations if secondary to fecal impaction, manual evacuation of fecal mass, after lubrication with lidocaine jelly, avoid catharsis. No hot water, soap, or hydrogen peroxide enemas. Outpatient care. Ongoing care. Follow-up recommendations. Periodic rectal exam. Patient monitoring. Consider impaction if there is one bowel movement every other day in patients with fecal incontinence. Diet: high fiber, 20 to 30 g/day, and at least 1.5 L fluid daily. Avoid precipitants, caffeine. Patient education. Kegel/sphincter training exercises are helpful but not sufficient for treating fecal incontinence. Prognosis: reimpaction likely if bowel regimen discontinued. 50% failure rate over 5 years following overlapping sphincteroplasty. Complications: depression and social isolation, skin ulcerations, artificial bowel sphincter, infection, erosion, mechanical failure.